of you to our storytellers, Dr. Celine Gounder and Ingrid Katz. And our guests from all over the world is very exciting because I think I've seen countries like Vietnam, Singapore, India, Tanzania, South Africa, Sweden, the UK, and of course the US and Canada. So for those who don't know me, I'm Nandini Woman, the founding curator of the Women's Storytelling Salon. It's always very exciting to see a great group of guests at our salons in DC, but this is a first for us. It's a virtual salon and a mixed audience of all genders. Normally we do these in person and only with women, but it's taken a pandemic to trigger this experiment. And so we thank you in advance for being patient. Myself, I'm a global health specialist. I've worked in global health for many, many decades in India and in the US. I've worked with different organizations like the Rockefeller Foundation, the World Bank, and a think tank called the Center for Global Development on a big HIV/AIDS monitor project. But as of 2012, I've worked as an independent consultant, which is in global health and which allows me the time to actually do something like this. And it's really been a wonderful journey the last 4 years. You can also browse our newly minted website to find out more about the salon and what we've done in the last 4 years. But very briefly, I just wanted to take you through a few things about the salon. So our vision is to make women visible and vocal in their leadership and participation in the workforce. And our mission is find it, own it, share it, which is meaning find it. We want women and girls to find their stories. We believe that every woman and girl has a story, and we want her to take the time to think about and construct her story in a deliberate way. Own it. We want women and girls to own their stories so that they aren't appropriated, modified, or completely forgotten by others. And we want women and girls to find their stories, own their stories, and then, of course, once they've found their voice and these assets, they can use them as they need to. And we feel that these stories trigger conversations about women's leadership and participation, inspire others to envision what is possible, and allow the world to celebrate and recognize women for what they're doing now rather than later. And these stories can also provide some insights as we think about the future of work and how the workplace can be designed to be more gender equal. But why is this important? And I don't know if any of you saw a very timely piece of news about a woman called June Almeida, who at the age of 34 in 1964 in Scotland spotted a new kind of virus with a halo and a crown, which was the first coronavirus. And she got very little recognition at the time and is finally being acknowledged for her virology breakthroughs long after she's even left this earth. And we just don't want this to be a continued status quo situation where women are recognized 50 years later and long after they've left this earth. So we want to make sure that you can find, own, and share your story. And we want to make sure that we can change that. So this is why we actually do the salon. So I'm just so excited moving to the actual storytelling part of our session today. I'm very excited to have Ingrid and Celine join us at the salon. I'm going to give you a brief introduction about them because after all, you're going to hear all their stories. And I'm going to do their introduction in a question form that I actually snapped off their Twitter profiles rather than their CVs because their CVs are way too long. So this is a wonderful, Twitter's, the best succinct form of capturing information. So Dr. Ingrid Katz. How does Ingrid Katz, MD, teach at Harvard Medical School, lead as Associate Faculty Director at the Harvard Global Institute of Health, Harvard Global Health Institute, see patients at Brigham Women's Hospital and Mass General in Boston, do research in HIV/AIDS in South Africa, educate the public on COVID-19, and be a wonderful mom and spouse all at the same time. I'm delighted to have Ingrid at the salon because we actually met at Johns Hopkins long ago as graduate students, reconnected a few years ago, and just this year we were selected as fellows in an inaugural cohort of women leaders in global health in the US at Stanford University called Women Lift Health. So we get to be colleagues again, and that's one of the reasons I can actually have her on the salon. Dr. Celine Gounder. How does Celine Gounder, MD in infectious diseases, treat COVID-19 patients at Bellevue Hospital, teach at NYU, comment on CNN as a journalist, host 3 podcasts, including a very trendy one called Epidemic, and run a not-for-profit organization called Just Human Productions, which seeks to change the way people think about health and social justice. An important vision for these times, and especially this particular time of COVID-19. So I'm delighted to have Celine with us. Ingrid brought her to me and I was like, oh yeah, I've seen her on CNN. And then when the invite went out, I got all these messages to say, oh, I know Celine and she's great. She's indeed great. And we're just delighted that the proceeds from this salon, from all of your ticket donations, will actually go to Just Human Productions to help Celine use her company, her organization as a platform to do all the great things that they want to do. So the theme for today's salon is disease detectives, clinical care, and communication in the time of COVID-19. So needless to say, a tiny virus has upended the world, bringing life to a grinding halt for a majority of us. But there are so many essential workers who are putting their lives on the line, like our grocery workers, people who are involved in bringing us food so that we can still survive in the comfort of our homes, and of course, our healthcare workers. And in this context, I just wanted to pose a few questions to create sort of the setting for this discussion. Did you know that women now comprise approximately 75% of the global health workforce and over 90% of nursing and midwifery professions? So we want to know, what is it like being a physician in New York and Boston during this pandemic? How does one become an infectious disease specialist? What does an infectious disease specialist do? And how do you use ID expertise in a public health crisis? And today we're just focusing on the US, and eventually, if this experiment works, we'd love to actually take this to other countries and hear from others working on COVID and global health, but also other things and other sectors. So to answer these questions, I'm going to dig right into the stories, and I will do this by triggering the stories with questions that I have constructed from a pre-salon discussion with both of the storytellers. Sorry, I need to take a sip of water. So we're going to start with, and just for those who have joined, we are doing the first half of the session as a as a storytelling session, and then we will do the second half as a interactive Q&A. So for now, if you can just keep your videos off and mute yourselves, we're just going to go straight into the questions. So I'm going to start off. I know this is not always an easy question to answer, but it's a fun one. To both our storytellers, how would you describe yourself as a professional today? Not your official titles. If you were marketing yourself for a job, what would you say if someone asked you what your qualities are as a professional? So short sentences, keywords. Why don't we start with Celine?
I would say that I care for vulnerable populations, and I try to communicate with the broader public about the needs of vulnerable populations.
That's wonderful. How about also telling us a few qualities about you as a person that make you who you are?
I am curious. I really like to explore ideas. I really value, for me, things like around justice are really important, and fairness in life. And so that's definitely something that is a sort of through line through all of my work. And then creativity. I really like to be able to think outside the box, to weave ideas and inspiration from across many different disciplines, which is probably part of the reason that I don't have a just straight up clinical job or academic job, I find that a little bit claustrophobic and frustrating, and like to explore many different things.
That's great, Celine, and I can totally empathize. Ingrid, why don't you give us a little synopsis of who you are in terms of qualities?
Okay, well, first, thank you for having me, Nandini. It's such
A
a treat.
pleasure.
And I love being here with Celine and all of you who are here in this first virtual space together that Nandini has curated. And we just owe you a great amount of gratitude for that. It's just so marvelous that you're continuing to lift up women's voices, and I think that's something that I'm deeply attuned to and grateful for. So thank you.
Thank you.
I will take the second question first because I think it leads to the first one, which is how do I define myself, or what are the characteristics of me? And I would say, I told you this, Nandini, I'm an empath by nature. I think the human condition is what leads me to all of my decisions in my career. And so all of the work that I do, whether it's focused on research, whether it's clinical care, or whether it's my engagement at the Harvard Global Health Institute, is really led very much in that line of focus, and really trying to understand how we can improve care for really the most vulnerable patients in the world.
That's great. So moving sort of to the next question, I normally begin at the very beginning of everyone's story, or which I call my origin stories, or rather your origin stories. But given the COVID pandemic and your critical role in this fight, I'm going to start backwards today a little bit and start with the stories about your life right now, because it's a very intense time. Both of you are very involved in the response. So I was wondering if you could actually tell us your about your role in the COVID response today, both in the US and globally, because both of you have a presence both domestically as well as globally. Maybe Ingrid, do you want to go first with, or Celine? Actually, why don't you go first, Ingrid?
Sure. So, as Nandini mentioned, both Celine and I are trained in infectious diseases. And I was joking. I was telling someone recently, I don't think anyone knew what this job was till about 2 months ago. I happen to be married to an amazing woman who's an oncologist, and she was always fielding calls related to cancer, and no one ever called me. So I said, wow, this is quite a difference now in the last few months. My focus prior to COVID has been primarily in South Africa around helping design interventions for people living with HIV to try to help improve their engagement in care. And so I come at a lot of this through the lens of HIV, and certainly the piece of social justice that's always been infused into the HIV epidemic. I also do some remote care right now through a virtual format. And then, of course, I'm on the launch pad. I'm on a backup call for Brigham and Women's Hospital as needed for inpatient care. And obviously, that's continuing to evolve each day. And I think the last thing I would say is I hope to lift up the voices of good and effective data-driven communication. And so I try to do that in any platform I'm on, whether I'm on media or Twitter. I really feel during this time, my job is to combat misinformation and to clarify really important messages that are getting out there.
That's great. And if I might actually ask you to think of a story around how you actually, as you said, got into this job that nobody knew, there was no job description. Can you tell us a little bit, a story about how your life has changed in the last 2 months as you continue, or rather as you emerge as a specialist in COVID-19, because nobody's a specialist, everyone's emerging specialist. So if you can think of a story that would highlight how you had to be very nimble on your feet to actually start working in COVID-19, that would be terrific.
Yeah, absolutely. So, I mean, I think that all of us in this field have had to be nimble over the last few months. And I think because this is an emerging field, everyone that I know has had to shift their focus. And that can certainly be challenging because a lot of us are used to kind of carrying on our path. Certainly, everyone in my community had their own separate spheres. And so I think really for me, it was watching it evolve over the last few months. I mean, really, when I saw that there was this outbreak happening in Wuhan and seeing it progress, I was very concerned, knowing the history of SARS, knowing just how global and how connected we are. I really started tuning in by Christmas, and certainly early in the new year, I started to get deeply concerned that this was going to become a global pandemic. And so, in that process, I think my background in HIV has been really instrumental. And I look to a lot of the leaders in the field of HIV in the 80s who were right in there taking care of patients, not knowing how HIV was transmitted, dealing with a lot of the stigma that came with that, and obviously just so deeply invested. And a lot of them ultimately moved their careers into the field of HIV. And it's going to be really interesting to see how many of us fully shift into this very specific field, or how many kind of continue in this area, but maybe have it as a kind of a side piece of what they do.
Yes, and that is so true, because I worked on HIV/AIDS as well, and I was thinking back as this was progressing to that time, and how the issue ascended the priority agenda in terms of policy and money, and of course all the politics of global health and the geopolitics of the world in general. So that will be really interesting to see, as you said. So thanks for that. And Celine, why don't we turn to you and ask you what you are doing right now, which is a whole lot of things as well, in terms of seeing patients. Maybe that's the one thing we can touch on now, because we'll actually touch on some of your other roles in the COVID-19 pandemic. So maybe you could tell us a little bit about patient care and what that has been like at Bellevue, perhaps with some stories that can kind of illustrate to us how intense it has been in New York.
Sure. So I've been on service at Bellevue sort of on and off. I do that clinical work part-time. So I was on service the first 2 weeks of January, and then against the first 2 weeks of February. And then I've been helping with weekend coverage since then. And I'm supposed to be back on service again first 2 weeks of May. So it's been interesting because it's sort of snapshots in time. And those blocks of time I was on in January and February, I was pulling all of the papers that were coming out about what was happening in Wuhan, the early JAMA and New England Journal of Medicine papers, and sharing them with the residents and medical students on my team and trying to teach them about it. And it was really interesting how, I mean, to me, this is such exciting stuff. You're seeing history unfold, and the way in which the science unfolds. First of all, it's happening at record speed. But just to see the stories around that, to me, was just so exciting. And it was really interesting to see among the residents which ones really understood what was happening, and which were still, as educated as they are and have medical backgrounds, just didn't really fully appreciate what was happening, that, how significant this was going to be for all of us. I think another thing that has been really frustrating at the hospital has been access to personal protective equipment. I think one thing that to me is a really important lesson here, and it's not just in this setting, but others as well, that when healthcare providers raise concerns about safety, those concerns need to be taken seriously. And if you look at, again, the science and the evolving science around this, I was speaking to people who are fluid dynamics specialists in the disease, in the transmission of infectious diseases, like Lydia Voriba at MIT and others like her. And, also looking back at some of what had been, researched about SARS and SARS transmission, MERS transmission. And it was very clear that some of the guidance that we were giving, saying this is only droplet spread, was not correct, and that there was the potential for aerosol spread, and that healthcare workers who were caring for COVID patients really did need a certain level of protection. And now that was inconvenient for hospital administrators because they didn't have the supplies necessary. And I think the messaging that, well, these other, you know, items, these other kinds of masks are perfectly adequate, was really a breach of trust, because that was supply guiding the policy, not science guiding the policy. And so then you have healthcare workers who question that. Some, not here, but elsewhere, have been fired over that. You have nurses' unions that are really pushing now for stricter policies around what level of personal protective equipment that they get. And there's this idea now of, oh, these unions are all whining, and, you know, they're making our lives difficult for caring for the patient. And this all goes back to the original breach of trust, where had they acknowledged the concerns, recognized the concerns, and, you know, even said, look, this is not, we agree, this is what the standard should be. We simply don't have the equipment. Here's what we have to offer, and then we will give you the option. How, you know, do you just want to say, you know what, I'm going to opt out right now, or take other measures, bring in your own? You know, I think that would have been a much more really respectful approach, both respectful of the fact that we are aware of what the science says, many of us, and we are concerned. So I think that, you know, that's another piece that's been very complicated here. I think, you know, if I remember the first time things really had changed at Bellevue, it was probably late February, and I was going in to help on a weekend day, and I got to the hospital. I had walked across town because it was right after New York City had shut down. I didn't want to take public transportation or a car, so it was like a 25-minute walk across Manhattan to get to Bellevue. And I get to Bellevue, and you know, usually there's people milling around outside. The streets were deserted. I walked in, and there's like these roped off areas where you're supposed to walk down, and somebody checks your temperature and it assesses you for symptoms. Only staff are allowed through, and if you're a patient, you're directed to the emergency room, but no family, no visitors. And they check my temperature, and I've been walking outside in the cold, so it reads like 94 degrees, which clearly my temperature is not 94 degrees. And then I, you know, walk in through the lobby, where again, there's usually lots and lots of people. There's an au bon pain cafe where you often see people grabbing coffee or grabbing a lunch and going on to where they're headed next, all deserted. And then walking to the back of the hospital to take the elevators upstairs, again, completely empty. And it was also really eerie on the hospital wards, because normally patients' rooms, the doors to their rooms are left open, so people can kind of go in and out and keep an eye on patients. And all the rooms were closed. Basically, the entire hospital had been taken over by COVID patients. We had been trying to clear everybody else out, realizing what was coming. And so the hospital was full of this. And so it was really quiet. Everybody was sort of keeping to their corners, you know, the nurses in their spots, the doctors, you know, you didn't have the usual bustle of physical therapists and pharmacists and all the other staff. And then every hour or so, you would get this overhead page for basically a code where one of the patients was having respiratory distress and they were needing to be put on a ventilator. And it was just a really strange feeling, because hospitals, you know, if you spend any time in a hospital, they're noisy places. There's all kinds of alarms and people doing things, and it was just quiet, punctuated by these overhead pages. So anyway, those are a couple of thoughts about, you know, what it was like, especially in that period of time.
Absolutely. And I can well imagine that, you know, with so many unknowns, it must have been very eerie to walk into your usual place of work to see something so radically different practically overnight. And I think you raised some really interesting issues around the notion of trust, which has come up in healthcare, but also in governance in many countries. And I think this is going to be a very interesting byproduct of the COVID-19 pandemic. Trust is really a big issue, both around, as I said, governance and also related to transparency and data issues. So this is really informative. I'd like to now, you know, actually rewind a little bit to the beginning of your story, because it's important. The whole point of this salon is for people to understand how you got to where you are today. So I would love to ask you if you could tell us the story of your first ever job that you had when you entered the workforce. So whatever it was, tell us a little bit about that job and how you actually got into it. As you know, I think a short story there would be wonderful. So maybe Ingrid, do you want to kick that off?
Sure. So as Nandini mentioned, we were at Hopkins together in the 90s, which according to my son is the dinosaur age. I was only 5 at the time, though.
Right.
So it was very precocious.
I was 7.
And I was getting my master's at Hopkins in the School of Public Health. Nandini was getting her PhD. And as part of the international health program, we spent a year abroad. And so during that time, I was in Vietnam. And it was a very interesting time to be there. I mean, it was really a country in a lot of transition. And I know some of you on the call may be living in Vietnam. Nandini obviously lived in Vietnam. It's a really fascinating, interesting country. And in the 90s, we were really among the first wave of Americans to really be moving there and working in the field of public health. I was there as part of my master's degree. And I was working with the Population Council at that time, which is a reproductive health organization based in New York City. And I think, my time there really informed so many of the other choices that I ultimately made in my career. I mean, to see, and again, I had worked in HIV prior to going to public health school. And certainly in the early 90s, there was a lot of transition in this country around understanding HIV and caring for people living with HIV. And I think going to Vietnam and really living during this time of massive transitions, appreciating very much how things were going to be playing out for people with health inequalities. And again, Vietnam was really transitioning also. I mean, there's still obviously the economy continues to transition in many ways, but really both a communist and a capitalist strain coming in simultaneously. I always joke the most fascinating street signs existed in Vietnam. My favorite was when you flew into what is now Ho Chi Minh City. There was a big sign in the 90s that says Coca-Cola welcomes you to Ho Chi Minh City. And I thought, does anyone else see some irony in this sign? Or is it just me?
And that
there are all these fascinating things that, you just have to keep your eyes open to see them. And so that really, I knew during that time I was committed to public health. I loved being at Hopkins. The people who I was surrounded by were and are so inspiring. And in many ways, I realized that was my community, perhaps even more than in medicine. And I wanted to pursue more training, whether it was in public health or in medicine. And I think my time in Vietnam really helped me see I really love the human contact that medicine can bring. I think there's nothing like that in kind of, high level epi positions, which is kind of the other thing I was thinking about.
So I'm going to ask you to hold that thought because I want to bring the next question about how you got into medicine after that. So I'm going to turn to Celine and ask her to tell us a little bit about what was her first ever job, and then we'll go into the medicine part of the story.
Sure. So it's funny, Ingrid. So Ingrid and I have actually known each other for a long time, and there's some parallels in our stories. But in any case, first job was right out of college. I took some time off before going back to public health school. So I was also at Hopkins for my master's in public health in the late 90s in epidemiology, and then went on to my medical degree and so on, just like Ingrid, actually. But before going to Hopkins, I took a year off to work in Washington, D.C. And so I went to Princeton for my undergraduate degree, and there were 2 Princeton alumni, actually a whole class of them, the class of 1955, that had decided to really develop a program for Princeton alumni to do public interest work. I think a lot of graduates of Ivy League schools often go into I don't know, law, medicine, business, like very straightforward, highly lucrative career paths. And there was this understanding that, so, the university needed to do something to give back more in a more significant way. And the two alumni that I worked with that year were Ralph Nader and Gordon Douglas. So Ralph Nader in the U.S. is very well known. I don't know if you'll know who he is, but he's a famous consumer advocate. He really helped to push through many laws around public health and safety, whether it was regulation of cars and highways to the Clean Air and Clean Water Act and many of the Environmental Protection Agency's regulations. So he has a really important role in our history of public health here in the United States. And Gordon Douglas was the vice president of Merck's vaccine division at the time, so in the pharmaceutical world. And so you might ask, why would this sort of, I don't want to say fringe, but like definitely, very left-wing advocate be pairing up with a pharmaceutical company executive? And each from their own perspectives had realized that there really needed to be more attention on diseases like tuberculosis. So Ralph was asking, why is it there's all this advocacy around HIV, but not TB and malaria, which are equally, especially at that time, equally big infectious disease killers. TB was the major cause of death among people with AIDS and still remains so today. And Gordon, coming at it from the infectious disease vaccine development, sort of clinical epidemiological perspective, also recognized that this was very much a problem. And so they had teamed up together and hired me and one of my classmates to work on this. And I was stationed in DC out of Ralph's offices. And my job for the year was really to spend time on Capitol Hill, meeting with legislative aides, legislative directors for various congressmen and senators. And a lot of that is understanding how our government is structured. So you have these committees and subcommittees with clusters, subgroups of senators and congressmen who really focus on specific issues. So trying to understand, those processes. Also meeting with people in the executive branch, the World Bank, all sorts of different organizations like that. And then also conducting congressional briefings where it's sort of like a mini lecture you give to staff that work on the Hill. And the whole point of all of that was really to advocate and push for increased funding for tuberculosis at USAID, which we were actually successful in pushing that through ultimately.
Great.
Which was really exciting. But I think what that experience taught me was that it's not enough to produce science, to be a good scientist. You also have a responsibility to communicate that science and to make sure it has an impact. Partly because at least in the US, much of our science is taxpayer funded. I do think you have an obligation to give back to the people who have made your career possible. So, and communication is fundamentally storytelling, which is
okay,
brings us back
exactly.
here.
So hold that thought because I'm going to get to that in a later question. But I wanted to actually ask you at this point, Celine, because I think it's a great story, is how you actually discovered medicine. And I like it because it has a personal connection to what your parents or your father wanted you to do and how that changed. And before you go there, I just wanted to say that it's wonderful to see the parallels between yours and Ingrid's sort of trajectory, and there's a good reason you all are friends, because there's a solid basis for your social justice sort of perspective in public health and medicine. So why don't we turn to the story about how you discovered medicine and what your dad wanted you to do.
So my father was from a very rural village in Tamil Nadu in India, and he was one of 5 kids in this sugarcane rice farming village. The whole family, they were farmers, and my dad was like the little runt of the litter. They would make fun of him because he was totally useless with the farming duties, but he was really good at school, and he ended up being the one who no one else in the family went beyond the 5th grade in their education. No one in the village. And he went on to go to Jesuit boarding schools on scholarship, and then later to the Indian Institute of Science, which for people who aren't aware, is sort of like the MIT of India at that time, and continued on scholarships, went to briefly Toronto and then settled in the United States for his PhD. And he studied engineering, and he saw that as, the way out, I guess, on some level, and a way to create jobs. And, many, many different reasons he thought that that was a really important career path. And so, I was very good at math and science growing up. I skipped grades. I was taking college level courses in mathematics as a high school student, and went to Princeton at 16. And my dad wanted me to be an engineer like him. He really wanted me to be the next Bill Gates. So studying engineering or computer science, and then getting an MBA, and and that,
as good Indian dads do.
As good Indian dads do. And it just didn't resonate with me. I was taking these classes, and I could not imagine a life or career doing this, for the rest of my life. And so I sort of hedged my bets. I studied both engineering and pre-med. And the reason medicine was starting to make sense to me at the time is it was sort of this idea of, yes, I'm good at math and science, but I want to use that in service of people. And medicine, to me, felt like the clearest way to do that. Now, that said, I know you can do that through engineering and technology and other fields, but for me, that's what I connected to. And so, really ended up pivoting in that direction. And it's funny, my dad at that time would say things like, oh, medicine is a poor return on investment because of all the years and spending, that you have to do to get the degree and the training. But, later in life, he did come around and really did recognize that that was the right fit for me.
Fantastic. So that's a lovely story. And I'm going to jump to Ingrid to actually talk a little bit about how you went from medicine to sort of an academic medical center for your choice of where you wanted to work as a physician. And then I'll go back to Celine to also find out her story of moving from medicine to both medicine and journalism. So Ingrid, why don't you tell us about your choice of, choosing an academic institution and what that meant for you and how you went about it?
Yeah, thanks. I mean, I think it's so funny. I've known Celine for all these years, and I'm learning all sorts of new things today.
Always happens.
I know.
It's a great thing, yeah.
So, I mean, I feel like I would love to say my path was clearly articulated in my mind before I started, but it absolutely was not. And I always put that out there for people because I think so much of this is an organic process. You make one choice that leads you to the next endeavor. And I think it's the willingness sometimes to take a risk that may be a little bit non-traditional, and really listening to yourself along the way, I think is at least what's worked for me. And I know I have a tremendous privilege. I did not have to make a decision guided on a need for survival. And so I think because of that, I felt a certain responsibility to be in a field where I was able to contribute in some way that was meaningful. Mm-hmm. So medicine, I tried to run as far away as I could from medicine since that was the family business.
Right.
And I was a history and French major, and so the fact that I landed in academia at the end of the day is kind of funny to me because I really can't say I had an intentional desire to be, an academic. And even now I feel like that feels like a very kind of heavy title for who I feel that I am. Because I think what this career has provided me is just an enormous amount of flexibility and an ability to wear, on any given day, I wear, 3 or 4, sometimes 5 different hats, and I can kind of put them on at different times. And so I think that is a beautiful gift that academia provides for people, that you have a lot of flexibility within your career so that you can perhaps see patients, do research, be engaged in policy and things like that. So for me, that's why I came to the Brigham with my wife to train. And we just really haven't left, the Harvard system since then, which is always a very shocking thing since I'm really not someone who tends to stay as still as I have. And maybe it's because the work I do is so global in nature. I feel like that kind of satiates that goal for me.
And it's great. And I also know that it's allowed you to do a lot of work in writing and communication. And maybe from the communication point of view, you can actually tell people a little story of how you did a wonderful time session with kids over and above the academic. So it really shows what a spectrum of things that you are able to do actually in your position at Harvard. So maybe just a very quick snippet, and then we'll turn to Celine.
Yeah, thank you. I mean, I think I've been very fortunate to be part of the Harvard Global Health Institute, and have tried to utilize that role when things come up. And I think someone had approached the institute to see if someone might be interested in speaking with kids through the Time for Kids, and I jumped on that, even though my son now is way too cool to really care at all about what I do on any given daily basis. But I really believe, as Celine says, in the role of communication and being very forthright, and gaining that trust from people is about providing accurate information, and that starts at such a young age. And kids are voracious for information, and so they asked me to be part of this, which was a treat for me. They're amazing young people, and I know they're going to go on to lead the world. So it's a wonderful opportunity for me.
That's great. And so it was a televised, or rather, it was a digital recording where you could speak to kids about COVID,
Right.
and answer their questions. So
Right.
that's great. So Celine, I'm rushing a little bit because I want to be mindful about opening this up. But Celine, maybe you could tell us how you actually took this leap of going from medicine to journalism and straddling many things that you do in journalism and communication alongside your medicine. So maybe a nice story about how did you get the CNN job? Like, how did that happen?
Well, these aren't short stories, I'm afraid.
You're the best you can do.
I'll just give some bullet points in terms of what led up to that. So
Yeah.
I stayed in academia first in the Harvard system at Mass General, then went back to Hopkins, finished my training there, stayed on faculty there, and by the time I left that job, I think of that in some ways as leaving academia, because even though I have a foot in that world now, it was a full-time thing then. And I was really disenchanted with what I felt like were very, frankly, colonial approaches to doing research in developing countries. It felt like you were mining people in those countries for your data. And I didn't feel like there was a lot being given in return. And that really did not sit well with me by the end. And so decided to leave that. And my plan had never been to stay in academia. I had wanted to go someplace like the CDC eventually. Had been offered some jobs with the CDC while I was there. Ended up taking a job running the Bureau of TB, tuberculosis control in New York City. And that wasn't really the right fit either, in part because of the phase the Bureau was in. It was in a phase of having to fire people because we were dealing with such huge budget cuts. And actually that really matters today, because the contact tracers we talk about, they are basically the TB contact tracers that are now being reallocated for COVID contact tracing. So, I had to go into this job. First 6 months were spent getting to know everybody, poring over spreadsheets, and figuring out who to fire. And that, I think that's very different from going into a job at a program where you're building something, you're being creative. And so that's why that really wasn't the right fit for me. And so ended up leaving that and taking some time off to figure out, okay, well, what next? And I was sort of reflecting back on so many of the things that I'd done up to that point. And there was this through line of communication of, what I had talked about earlier, and having continued to do that kind of thing. And so it was around 2013 that, I had absorbed some degree of lessons from my husband, who's worked in journalism for years, very different kind, sports journalism, but at least I had an understanding of, to some degree, how the business worked. And so reached out to other friends who were both in written publications and TV, and kind of got my foot in the door. I mean, that's one nice thing about being in New York, is this is the media empire in the country. And so started doing some television, started doing some writing, and then a bit later got interested in podcasting around 2017. And we can talk about this later, but each medium has its pros and cons, depending on who you're trying to reach and what you're trying to communicate. And then the CNN deal. Well, I've been doing stuff for CNN for a while, actually. This goes back to the Ebola epidemic. But when they have a big story like this, it could be an election, the presidential election, it could be an outbreak. They will usually hire on some analysts, or what they also call contributors, to really supplement their coverage, because their usual sort of stable of reporters and so on, it may be outside of their area of expertise, or just the volume that needs to be done, they need help with. So did become exclusive to CNN earlier this year, and that's been really fun. These are people many of the producers and anchors, hosts I've known for a while now, and so it's fun to go on and really have a conversation with somebody.
Great. Okay, so I'm going to ask one very quick question, and then I'm going to turn to the audience. Looking back, what helped you the most to get where you are today? Just something that people can hold on to as a takeaway, in terms of when you look back at your life and what you've been able to accomplish. I'm sure there are many things, but what is one of the most important things that stands out for you? So, Ingrid, do you want to go with that? And if we can make this quick so that we can turn to questions.
Okay. I'll say certainly my family, and their unwavering support. I'm just so deeply grateful, and the community I'm in. And then I think really kind of being a little bit of a stubborn optimist, and persevering even when things get hard. I think being willing to take the long road is absolutely key.
Great. And Celine?
My answer is twofold as well. I would say one is not caring what other people think is really important to do something out of the box.
That's a good story. Maybe you can just quickly say that one, the one you shared with me about taking the job in journalism with your Cornell professor.
Oh, well, it wasn't with a professor of mine. This was around 2010. I hadn't moved to New York. My husband and I had not moved to New York yet. And I was already starting to think about this path, and was speaking to one of the chairs of infectious disease here in New York. I won't say which, there are a handful of them, so maybe you can guess. But I had met with him and had mentioned that this was an interest. And he looked at me and he said, well, that's a really stupid idea. And, I think you have to realize where the reaction, the feedback is coming from. People are going to advise you to do what worked for them, what made them successful. And if your values don't align with theirs and your desired career path is not theirs, then their advice has limited utility. And I would say the second piece is having somebody like my husband, who was cheering me on the whole time and really supportive, even when I was taking some really big risks. And realizing there's a select few people in my life whose opinions I really do care about, and this is one of them. And really focusing on that and people who really care about me.
Great. So I'm sure people have I have so many more questions, but I think I'm going to turn to the crowd. And I think the first question we have is from Andrea. If you could unmute yourself and put your video on so that people can actually see you ask your question about your life of asking about what their opinion is about living a life of limited movement and limited social interaction. So Andrea, do you want to come on? And I'm going to try and push you to be fast so that we can maximize the questions here. Is Andrea on? Great. So go for it. Just ask. You can just be brief. You have to unmute yourself. On the bottom left. Yeah. Oh, we can't hear you. Okay, then I'm going to ask the question while you're there. She says, I'd like to know more about their professional opinions regarding how long do you think we will be living a life of limited movement and limited social interaction. This is from Andrea in Sri Lanka.
Celine, you want to take that one?
Yeah, I think this is going to depend a bit on the region that you're in and what specific measures have been taken and how well transmission has been controlled where you are. I have to confess, I don't know enough to comment specifically on Sri Lanka. So for example, here in the United States, I think each state is, or cluster of states, region, is going to be taking its own approach for better or for worse. I think states that have done a better job of flattening the curve, as we say, so reducing transmission to the point where hospitals can actually cope with the number of patients that are sick. Those areas, as they start to reopen, many of them are looking at, do we start to do contact tracing and testing? New York is, one of them. Massachusetts, where Ingrid is another, that have been pretty proactive on that front and trying to develop that capacity. So I think those states will be able to lift social distancing restrictions for a period of time where the contact tracing and testing will control things well enough. But I think if you look back at how this played out with, for example, the 1918 flu pandemic, you are going to see increased transmission, and the tracing and testing will mitigate that, but it won't prevent all of it. And so eventually you will hit a threshold where you have to reimpose restrictions, and probably will have to be doing this in cycles of on and off. And so that's where, the testing and tracing is important, because it helps you figure out when you hit that threshold, and to be more calibrated about that. But I think we are looking at cycles of this, frankly, until we do have a vaccine, or, I think it's less likely that we would go the approach of a medication like what we do with HIV with pre-exposure prophylaxis, a pill that you would take every day. But I think until we have some sort of pharmaceutical intervention, I think we are looking at, social distancing in some form, probably for the next 18 months to 2 years.
Great. Ingrid, do you have anything specific to add to that, or should we move to another question?
Yeah, I'm in full agreement.
Okay, great. Okay, so then let me move to the question from Maya. Do you want to unmute yourself, Maya, and put your video on so we can see who you are? Do we have Maya?
Yes, I am here.
Okay, great. Do you want to ask?
I'm trying the video, but it seems to be competing with something. If you don't mind, I'll stay on the audio.
Okay.
I was wondering, just based on the observation, it seems like that public health attracts a lot of female scientists, female doctors. Is there something specific about public health that makes it attractive? And again, it's a personal observation. It's not based on data.
Interesting. I don't know the gender breakdown in public health. I don't know, Celine, do you know, or Nandini, do you know the gender?
I know the more aggregate one in global health, I think is, no, actually it's 75% of the workforce, so that's globally right. all health workforce, and 95% of nursing and midwifery. So I don't know in public health how that breaks down, but based on being in School of Public Health and then in public health, yes, there are a lot of women, but there are also a lot of men, so it's hard to say. I wouldn't know how to answer that question, but please feel free.
Yeah, no, I'm also not sure. I know I can comment fully since I don't know the gender breakdown. I know in my very personal sphere in global health, there is actually a very large cadre of women who I work alongside, both here and in South Africa, almost entirely, actually. It's interesting. I realized that the other day. I work with very few men, and that it was not the case 20, 30 years ago. I think all of our mentors, all these very senior people in the field, were way more men than women. And there has been a dramatic shift in terms of that workforce being predominantly women. I could speculate as to why that could be, but I would say there has been that shift for sure that I've noticed.
Great. And Celine, anything to add to that, or?
I think that if you look at the upper rungs of this, it is still male dominated. If you look at who are the people in charge, at least relative to the proportion that are women in the field. And I think some of this has to do with remuneration, and also if you look at, there are different ways to pursue, just even in the academic sphere, there are different ways to pursue a career in global health, and that could be through a public health school, that could be through a school of medicine. My observation has been that the men tend to gravitate to the School of Medicine, and those tend to be more highly paid positions. And so we've seen this in other fields where the more women enter into a field, the pay goes down. And I think that's a really unfortunate thing. It shows, something about how we value work. But I think there is something there. I just don't know the exact statistics to quote them either.
Right, and there is actually really a lot of good research, which I don't have at my fingertips, which really does show that when women move into a particular profession, the value of that profession decreases quite substantially, and that's interesting research for evidence for the future of work. How do we really think about work and design that so that it's more gender equal? So while we're on this topic, there's a lot of questions coming in, so I want to make sure that I keep some kind of a thread here. So I'm going to ask Hina from South Africa to unmute herself and put her video on and ask her question about women and mentors and support while we're on that topic, and then I'll move to another theme. Hina, do you want to unmute?
Yeah, sure. Can you hear me?
Yes, and can you put your video on? It's on?
Okay. Yeah, it is on. Okay. Thank you. This has been such an interesting conversation, and what I would really be interested in knowing is to what extent women have played a role in your lives in helping in your advancement. We often hear about women behaving like crabs and bringing each other down. And it's always been disappointing to me that there aren't enough women out there acting as mentors and support systems. In my own experience, sadly, it's usually been men who've helped me advance and women who have come in the way of it. I know that it isn't a unique experience. I'd just love to hear about what your experience has been about the women in your lives and what kinds of support systems that they have been in advancing your career.
Great, thanks.
Yeah, great question. I can say for sure that I've had some great women mentors and role models. I'm surrounded by very strong women. My own mother, my mother-in-law, my wife, they're all extraordinarily competent women who have had or have very active careers. And so I think that's a very normative space for me to come from. And I think that in the community that I've worked in, as I mentioned, global health actually has a large number of women now. Mm-hmm. I would say my direct mentor, I have had a long string of direct mentors who have been men. And I think that's a product of a shift in time. Mm-hmm. And, one of the things I'm deeply dedicated to, and I know a lot of women in my group is mentorship. I think that's something that I take very seriously. And so I do think that, as we continue to grow, it's so critical to lift everyone up. Everyone succeeds when we all go up together. So, that's just been my experience of it. I don't know, Celine, you might have some other thoughts around this.
Yeah, I think like you, most of my mentors, especially the closest mentors, have been men. And as you say, I think this is a generational sort of thing in large part. I have had some female mentors sort of more as not so much on a project per se, but more sort of on a personal level, people who were in the field, who I could bounce ideas off of or reach out to, and that's been nice as well. But I can't say, I'm trying to think if I've ever had the experiences of a female mentor of any kind really trying to hold me back or put, I think for me, the mentorship I've gotten from women is really more in the form of colleagues as opposed to somebody who's, ahead of me trying to bring me up behind them. I think the other thing I would say is a lot of the mentorship you get in academia, some of it is truly generous. Some of it is, how can I put you to work on my projects and it's going to be mutually beneficial? And there's a difference. There's this idea of what is it to be a mentor and what is it to be a sponsor? And right. A sponsor is really turning over some degree of power to somebody. Right. Truly empowering them. Mm-hmm. And that is not something I've experienced until very recently with somebody. And so that's been really refreshing. But that was not my experience for most of my career.
Okay, great. and we could, discuss these things forever, but I want to get some other questions in. Amina Mahmood from Singapore Health Duke, NUS Global Health Institute. Can you unmute, please, and put your video on and ask your question?
Hi, it's late here, so I'm lying in bed.
Of course, no worries. Okay.
It was great to hear you guys, and thank you for organizing this. So both of you mentioned that you kind of one of your focuses was vulnerable populations. When you introduced yourselves. So could you reflect on how you were bringing that focus and that kind of part of your being into the work you're doing with COVID-19 now? Because it'd be really interesting to see how that plays out, because it's a key concern of mine always. Thanks.
Great, thank you.
Yeah, I mean, I can't emphasize enough how critical that lens is and is going to continue to be, both domestically and globally. I mean, we already see it playing out here. There's no question around racial disparities, socioeconomic disparities. I mean, I think I like to call ID we're the ultimate locavores, in the sense that we very much everything about infectious diseases is informed by the local environment and the context with which you're in. And so in this space, COVID is going to be informed, and how it plays out in all these different settings is going to be informed by the setting that you're in, and augmenting the inherent disparities that are already there. And I think that that's really the challenge we face right now is, will we just kind of let this be another situation where there's disparities, how sad, or will this be a call to arms to say, wait a minute, we can't do business as usual anymore? And that's, in every context that we face, certainly domestically and also globally. And I think obviously different countries are going to be handling this differently, but there's no question that when you have a large pandemic like this, it really exacerbates fundamental inequalities that are already there, and attention has to be paid to that. Otherwise, it will just continue to augment.
Right. Celine, anything to add to that, or can I jump to another question?
I think it depends a little bit. So I can sort of list off some of the different vulnerable populations I've worked with over time. So obviously here in New York City, undocumented immigrants, African American communities that have really suffered from health disparities for many, many decades, really generations. I've worked with Native Americans out west. Some of you may have heard about what's happening with the Navajo Nation right now, and the rates of COVID there. And I've been speaking to my colleagues about what they're doing out there. And like Ingrid, I've spent much of my career working in sub-Saharan Africa. And so, if you look at just say the Bellevue experience, when I've been there, almost every patient I have seen has been a Spanish-speaking only undocumented immigrant. And it's because these are people who, one, are afraid to seek care until late in the course of disease. Two, they have a lot of the underlying medical conditions that put them at increased risk, the diabetes, the high blood pressure, the obesity. Three, they're working in service jobs. They're still having to go out into the community. They're living in more crowded circumstances. They're taking public transportation. And so I think understanding, as Ingrid said, the local environment and what contributes to these disparities. I just hope that we do take notice of this and understand this. I think this is something, both Ingrid and I have worked in HIV for a long time. We've seen HIV become entrenched in some of the most marginalized groups. And that's only gotten worse. And to see the rate at which COVID has already really become entrenched in certain marginalized populations has me very concerned about the future here.
That's right. So related to that, two people have similar questions, and I'm going to ask them to decide who wants to ask the question related to this issue. Gauri Divan in India and Surabhi in the US. Whoever puts on their unmute first and their video first gets to ask the question because they're similar. Oh, Gauri left. Okay, Gauri left because it's late in India. Okay, so Surabhi, why don't you go with your question on Is Surabhi there?
Yeah, I'm here.
Okay,
I think I can't start my video though.
that's
So
fine. Just ask your question.
so just I'm not a public health professional. I'm more a rural development, community development perspective here. Asking because of your work with vulnerable populations, what is in their best interest? Is it to continue this shelter in place and isolation policies, or to open up the economy?
Mm, that is such a tension. And Celine, maybe you should speak to that.
Yeah, this is one I definitely spent a lot of time thinking about, and I think it's a false choice. And the reason we're being made to make that choice is because we haven't thought about an economy where we're not basically making our profits off of a certain class of individuals. And I think that is the major problem. I think understanding that, at least in the United States, our healthcare is tied to having a job. If you had a system where everybody was entitled and had healthcare, there wouldn't be the same pressure to go back to work. If you had a real social safety net where things like some level of housing, some level of just support for your day-to-day necessities were guaranteed, we wouldn't be in this situation. And I find it extremely concerning that there's a lot of pressure from the top, from people who can frankly afford to, they have the option to continue sheltering in place and teleworking while they send the people working for them back to work. And they're the ones who, the people who are working on the front lines will be bearing all the risk, and the people at the top will be making all the profits. And I think that system of government, of economic organization, that's what needs to change. And we shouldn't have to be making that kind of choice.
Great. I'm going to then shift to a question from India. Priya, Nanda, do you want to ask either of your two questions that you've put up? Priya, do you want to unmute yourself? One is on recognition of female health workers, and then you had another one which is also really interesting about biosurveillance or over personal autonomy. Priya, can you please unmute yourself?
Okay. Unmuted.
And
Hi, Nandini. Yeah. I'm going to do a googly. I'm going to ask one person one question and the other person one question.
Okay.
Allow me that.
Quick.
So, Celine, your question is biosurveillance over personal autonomy. And to Ingrid, I'm going to ask you, all of a sudden, I work on health issues. All of a sudden, the world today recognizes how undervalued women health workers are. They're poorly paid, invisible, and undervalued. Do you think the pandemic is going to reverse and bring more power finally to health workers?
Mm. So on the surveillance question, I am very concerned about some of the developments, less specific to, say contact tracing here in the United States specifically. But if you look at some of what's being developed in the private sector, for example, Peter Thiel's Palantir, which is drawing data from so many different sources, public and private. It really is. Oh gosh, what was the name of that movie with Tom Cruise? I'm forgetting the name. Minority Report. There is really the way in which that they would be predicting, for example, who's likely to commit a crime. The idea that you would punish that person when really the predictors have much more to do with socioeconomic status and health disparities and so on. And so you're doubly punishing somebody even before they've done something. I think there's something really concerning about these surveillance systems and how they're being constructed and who's in control, and that there's such little oversight. Here in New York City, I've been speaking to the public advocate's office, Jumaane Williams, and some of the city councilmen, who've also expressed concern about how contact tracing is going to be done. And there are differences in terms of the, app-based, there's a Google, Apple approach that's being floated. But right now, my understanding is that would be opt-in here in the United States, which means that it would have limited value, frankly, for the hardest to reach populations. And then there's debate about even just old-fashioned contact tracing, face-to-face or over the phone, conversations, and how that data is held. So I think even without fancy technology, how do you maintain people's privacy? and respect for them and their autonomy in the midst of a pandemic is really challenging. I mean, this goes back also to the days of HIV, and so we've had to shift some of our ideas about reporting and so on over time as a result of that.
Excellent. Ingrid?
Yeah, the question I think related to will there be a higher recognition of healthcare workers, and particularly given the community health workers are vast majority are women. You know, I have to say I think this is my stubborn optimism streak, that I feel like HIV completely changed the landscape of how we think about providing care for people. It opened up a new world that we had never anticipated, and it was so and is still so utterly devastating. And so I have this piece of me that has to believe that COVID is going to have an enormous impact as well. And I don't know yet. I mean, we're living this history right now in this moment. You will tell your children and grandchildren about this time and all of the ripple effects. And I hope that one of those effects is a real recognition of community health workers, of the vast majority of care globally is provided by women, and that there is a recognition for that. That's my hope.
I think that's a good hope to have. It's good to be optimistic. Yes, I share that. So I think let's move to, there's a question about data, and that's from Preeti in London. Preeti, can you please unmute yourself and put yourself on video and ask the question?
Yeah. Hi, everybody. I'm Preeti from the UK. So my question is, Celine, you had talked about the extraction of data from, you weren't comfortable with some job that you did because of the way countries were treated, and that you were extracting data from them. So my question is, what would you see as a favorable model in sort of making it more equitable, and what would make you make you more at ease?
I think this goes back, and Ingrid can speak to this as well. The academic business model, and it is a business model, is very much dependent on grants and grant funding. And then you're measured, basically there's a need for quantitative measures of your productivity and quality of your work. And so in the case of academia, it's number of grants and number of publications. And the problem with that is that very much is at odds with building capacity, training people locally, and everybody who I have known, at least in the Hopkins setting, who really tried to go down that route was very frustrated, and those who remain frustrated, or they've left. And it's because it's not an environment that has a way of rewarding alternate career paths. So for example, me being on CNN, hundreds of times, or publications in, various different leading magazines or newspapers, that is not valued. There's no way to count that towards your accomplishments or productivity. And so I think having a way to recognize that you've built a program, that you've trained people in country, that you have had a concrete impact on whether it's clinical care or public health or policy in these countries, that's really what needs to happen. Because if you don't provide the way of measuring impact and rewarding for impact, it's going to be very difficult for people to make a career doing that.
Great.
And what's going to make that change?
Well, that needs to come from the institutions. They need to decide this is something of value, and there needs to be a way to monetize it, frankly. So you need to, it's a business, academic institutions are not benevolent institutions. That's so right. You need to figure out a way to monetize it.
Again, that's the topic that we could go on forever, and this is the constraint of doing this in an hour and a half. So I have one last question that I'm going to squeeze in because it's a good inspirational question before I turn to closing, and that's from Laura Hemeke in the US. Laura, do you want to unmute yourself and put your video on and ask your question about young people?
Yeah, Nandini. Yeah, sorry. Let me see if I don't know the video, but got it.
Okay.
I asked that question. It feels like a lifetime ago because I got so into the discussion and fabulous. Probably like both you, Celine, Ingrid, and Nandini, I'm getting a lot of young people. Obviously, the interest in public health, global health continues to grow as it has over the last couple of decades. But I'm kind of struggling, like what young people who really want to get into what's happening now and contribute. Many of them that I'm talking to are just finishing their master's in public health, like now or in the next month. And sometimes I struggle with the best advice to give them. So I'd love to hear from both of you. Thank you. And thanks for a great salon.
Thank you.
I'll give a very brief answer and then I'll let Ingrid close because she's the more inspirational, optimistic one. I would say there's going to be, at least in some places, massive hiring of contact tracers. I know in New York they're looking to hire probably some 10,000 or more people to do this work. And they're going to need people at all different skill levels. But I think if you're willing, I think this is a situation where it's all hands on deck and sometimes it's grunt work. But if you really want to be in the trenches and witnessing what's happening and how things work or don't, I think signing up to be a contact tracer would be an amazing way to understand more about the epidemic on the ground.
Yes, fantastic. The whole sort of epi-army, as it were.
Yeah. I mean, I think that's such a great point, Celine. I mean, I think, so, since I'm in the academic world, I do see a lot of young people, and I have the great fortune of we're trying to pitch a course for the fall for the Harvard undergrads on COVID and really teaching it real time, which is an interesting conversation to be had about teaching courses that may have a lifespan and the importance of still teaching things that are absolutely critical at that moment. And I absolutely agree. I mean, at Harvard, the number one, they call it secondary, which is really like a minor, is global health. It's hugely popular. People, I mean, I'm so heartened that young people are so conscious and, as my friends would tell me, woke to all these things, right? That I certainly wasn't aware of in my teenage years, or, I mean, I hope by early adulthood I was, but, I have to think that continuing to remain engaged and productive as a citizen, whether you're doing frontline contact tracing or whether you care about other things. I mean, there's roles for people who are interested in the impact of climate and health right now. That's such a critical piece of this, and how, we have migratory populations. So maybe you want to be involved in a migrant community. If you speak more than one language, you could be helping maybe with translations of materials right now. I mean, there's so many different roles that people can be playing. So I would just advise young people, play to your strengths. If you have special talents or gifts, use them and go in the path that you believe in. There's almost certainly going to be some connection to this pandemic at this point. And so, continue to use that strength to your ability.
Yeah, those are great tips. And I also look back to the time that I was entering graduate school at Hopkins and AIDS was on the agenda, and people were like, public health, what's that? They didn't know that. But then literally in the decades that followed, it's amazing how many young people went into global health and continue to do so. So this is yet another opportunity, and I'm sure they'll all have jobs very soon. But as Ingrid and Celine have said, I think you kind of have to follow your passion as well as your conviction and do what really you want to do that fits into what's currently available. So I think there are lots of opportunities. Well, on that note, because we're getting to 12:30 and I like to stay on time, even though I'd love to continue the discussions, I just want to say that, clearly, in this case, Celine and Ingrid have had similar paths but different paths, and it's always wonderful to see how different people come from different sort of origins to similar positions doing such great work, whether it's in infectious diseases or in any other aspect of global health or any other sector for that matter. So I entitled the salon as disease detectives, but I want to end on a note to say that I really would call them disease divas, because they're taking on so much of the work in COVID-19, based on all of the experience that they've had before. And I think this is where I like to highlight that, we all as women and even men, it's not like I want to leave men out of the equation. We have our past and our stories really are our assets that allow us to then move to the next phase of whatever we want to do, and we can really build on that. And this is a wonderful sort of example and illustration of that from both our wonderful doctors and storytellers here tonight. Today. Today for me, tonight for some of you. But on that note, I wanted to thank our storytellers. Those are amazing stories. I wish I could do them in more depth, but hopefully this will trigger you to think about your own story and perhaps document it for your own purposes. It's so important to own it and then use it as you see fit, because really it's a very valuable asset that no one can take away from you. So I encourage you for that, and thank you for your time and your stories. I wanted to thank all the guests who've logged in from all over. It's been wonderful to have you on. I wanted to thank my fellow quarantined volunteers, Mira, my niece, and Ela, my daughter, who are sitting on the floor next to me, managing all the tech. Couldn't have done it without them. And for those who are new to the Salon, again, welcome and thank you for joining us from all over the world. And please do go to our new website and follow us on social media. And we would love it if you could comment and share some thoughts and pictures if you happen to take them, photographs from this actual salon. So on that note, I'm going to say bye to everyone. Thank you again. And we will see all of you hopefully soon in another salon.
Thank you.
Thank you.
Thanks.
Bye.